Okay. Well, thank you for attending and taking time out of your evening tonight to join us. Batty, I'll get you to help advance the slides. So, first thing I'd like to do is introduce myself. My name is Rose Young. I'm the medical director for the Office of Lifelong Learning Physician Learning Program at the University of Alberta. And I'd first like to acknowledge that we are on traditional territories across Canada of the many First Nations, Métis, and Inuit peoples whose footsteps have marked these lands for centuries. So on that note, I would like to introduce the speakers tonight in the order they will be speaking, and it is my great pleasure to introduce the roster. So first up is Dr. Peter Sargious, who is the Senior Medical Director of the Diabetes, Obesity, and Nutrition Strategic Clinical Network, which will shorten as the DON-SCN. He's also an Associate Professor of Medicine in the Cummings School of Medicine at the University of Calgary. He is joined by Kathy Dimitruk, who is a Senior Advisor for the DON-SCN, and who is part of the Virtual Diabetes Prevention Project team and is a registered dietitian and certified diabetes educator. Dr. Jane Ballantine is a community-based primary care physician with a special interest in diabetes. She is a clinical associate professor of family medicine at the Cummings School of Medicine at the University of Calgary. And we also have Catherine Joseph, who is a manager of the DON-SCN and is the project lead for the VDPP, which I will now invite Dr. Sargis to give us more information about. So welcome and thank you for coming tonight.
Thanks very much, Rose, and thanks to you and the whole Lifelong Learning team for having us. And thanks to everybody who's made time this evening to hear about the Virtual Diabetes Prevention Program in Alberta. Catherine, I'll go to the next slide. So in terms of objectives for the evening, we wanted to give you a little bit of a sense of the current state and burden of prediabetes in the province, and learn a little bit about some of the options that we've spent the last several years exploring out of the Centers for Disease Control and Prevention in the States related to diabetes prevention, and then describe a little bit about our experiences with our pilot program, which has been running since March, February of this year, and hope that you guys are in a position to see the value of adding this option to the care that you offer patients who you've identified with prediabetes in your practice, while we study the value of running a program like this within the province of Alberta and sustaining it. So those are our goals for the session. Defined as somebody who meets criteria for overweight or obese with an A1C of 6 to 6.4%, we have north of 600,000 people estimated in the province of Alberta who have prediabetes based on CDA estimates. Moreover, the CDA also has documented that among the provinces, Alberta has had the largest increase in diabetes over the last 10 years and is projected to continue to have the largest increase over the next 10 years. Within the province, the SCN has identified that as a priority. And a year ago, a national diabetes strategy, a federal bill supporting a national diabetes strategy received royal assent, and that also identified diabetes prevention as a priority. So in terms of a solution, what we need is a diabetes prevention program that's cost-effective, evidence-based, and that could be accessible to all Albertans. And thankfully, we've had the opportunity to identify those kinds of options. I don't know how many of you will remember the DPP study that was done in the 90s, but the Centers for Disease Control and Prevention in the States has taken the findings from that, and what they've created is a program to evaluate providers of a service that would claim to be able to offer those results in a real world setting. The original DPP trial was based on a 12-month structured lifestyle intervention program supported by personalized coaching. Since the original study, it's now been demonstrated to have efficacy, whether delivered in in-person modalities or virtual modalities. And as you might imagine, the option for virtual delivery can dramatically impact the cost of delivering the program. And the outcomes are quite dramatic for those patients that have enrolled, having already demonstrated criteria for prediabetes. Their risk for developing type 2 diabetes after enrollment in the 12-month program can be reduced by as much as 58% or even more for older patients. And those results are achieved through proximal outcomes of a 5 to 7% weight loss with the addition of the recommended 150 minutes of physical activity per week. So that's the program that the CDC supports multiple providers in evaluating, and they provide ongoing accreditation or certification to providers so that potential customers of those providers will feel relatively assured that the program is delivering on its promise of actually preventing diabetes. In terms of benefits, people who participated in the program are 1/3 less likely to develop type 2 diabetes than people who didn't. And those benefits might be seen in the near term or as far out as 15 years after participation in the program based on long-term follow-up studies. And obviously, without intervention, many of the people with prediabetes will go on to develop diabetes within the next 5 years. In terms of the partners that are involved in this undertaking, with the DON-SCN, we've had the good fortune of gaining the interest of Alberta Blue Cross in working as the other provider in the province who would engage with the technology providers and sustain the program within the province. And we've had excellent support from primary care networks and the primary care community at large. There's been involvement not just of RSCN, but the Innovation, Evidence, and Impact Group within Alberta Health Services, Health Systems Knowledge and Evaluation, and the Primary Healthcare Integration Network. And after several years of exploring the options that were out there that met CDC certification and conducting an RFP competition to identify a technology provider that would want to compete to have that service offered in Alberta. We've identified Yes Health out of the States as the program provider. They provide the coaching through a mobile app, and that's an in-the-moment individualized coaching related to aspects of nutrition, physical activity, and wellness using certified health coaches. And importantly, in addition to the virtual delivery, they've used some artificial intelligence technologies to boost the responsiveness of their coaches and the engagement that patients experience when they're on the platform. And in terms of the pilot objectives, we don't need to repeat an efficacy study. What we need to demonstrate is that it's feasible to implement a program like this in Alberta and at least demonstrate that we're achieving the same kinds of outcomes. And what we want to do is assess the benefits in terms of predictable outcomes for patients that can be improved against the cost of preventing those outcomes so that we can sustain the program going forward as what we call a value-based healthcare approach. I won't go into details about the value-based healthcare modeling that we're doing, but we can discuss that in the panel if people like. It's very early days. We've had just over 100 people enroll, but to the outcome of seeing DPP outcomes validated in the Alberta population, we're seeing that already in the short period of time that people have been enrolled in the program, with an average weight loss already of almost 3% and a range from 1 to 10%. Those are early results. And I think with that, I'm meant to hand it over to Kathy now, who's actually going to demonstrate some of the functionality of the S-Health platform.
Thank you, Peter. Yeah, so I'll just go through this slide first, and then I'm going to switch over to my phone and show you how the app works. So just to give you a little more details about how this program works. So as Peter mentioned, there's this app, and Yes Health is the provider of the diabetes prevention program curriculum. The health coaches compose of registered dietitians, exercise specialists, and psychologists. They've all had health coaching, diabetes prevention program training. And for the purpose of the pilot, they did hire an Alberta coach who is a registered dietitian from the primary care world, who is helping support the other coaches with the Alberta context, as well as working with the Alberta participants to ensure that she can respond to their questions around local needs. The participants also receive a free Bluetooth scale in the mail when they sign up, and this scale does talk to the app. So the patients simply step on the scale and it records their weight. The coaches are available from 8 to 10 p.m. daily our time. And as we mentioned, there's in-the-moment coaching and artificial intelligence technology. So no logging what you eat, you simply take a picture of your food, and the artificial intelligence assesses the portion and types of food on the plate and relays that information to the coach, who then provides almost instant feedback. Part of the project for the pilot, we will send you a monthly report on your patient's progress, detailing out that they're still enrolled in the program and what changes they've had in weight and when their next A1C is due. So we are measuring A1Cs at baseline, 4 months, and the 12-month mark. So I'm just going to switch over to my phone now and demo the app for you. Okay, so here we go. So this is what you see when you open your home screen. Participants can individualize their schedule, what time they eat breakfast, when they want to do physical activity, so they can set this up however they like. And as I mentioned, no logging of food. You just simply hit the camera by the meal and you take a picture, and then you can also add details, written details if you like, that the coaches will then analyze. You can also, as I mentioned, log your activity. And if you do have a Fitbit, it is compatible with Fitbit. Unfortunately, it's not compatible with Apple, but it will automatically upload your Fitbit minutes when you do exercise. Then if you go to the progress tab at the bottom, it will look at your weight, what percentage of healthy meals you're having, active minutes, and well-being activities that you've completed. So I'll just show you the weight here. So it does default to a 5% weight loss. You can change that if you want to have a bigger or less goal for weight loss. And then, as I mentioned, when you step on the scale, it automatically records your weight and tracks your progress. For your food, I'll just show you how the picture taking works. So you can set goals for nutrition, limit daily sugar, skip late night snacking, etc. So here's a picture, I submit it. And as Rose mentioned, I am a registered dietitian, so I've been testing this app now for 47 weeks, and wearing my dietitian hat, I'm very impressed with the feedback and how this works. It's extremely user-friendly and really motivating. So this was some spinach with some cottage cheese and raspberries. And again, almost instantly, as soon as I submitted the picture, the coach responded with her feedback to me. She said, way to choose leafy greens for your foundation to provide fiber and nutrients. Cottage cheese is an excellent source of protein, and berries boost antioxidants. So nothing to improve here, but just, very motivational. This was a taco salad. Again, I did write in that it was a taco salad, but they didn't need their artificial intelligence is able to assess what is on my plate. And she again gives me very motivating, supporting comments and gives me a suggestion for a dressing of mixing plain Greek yogurt with salsa to also increase the protein. And then I wrote back, great suggestion, thank you. And she wrote me again. So I think this program is really different from other programs where this in the moment feedback. I was quite surprised how excited I was when I got a message back right away. And what's interesting, it's not front-loaded education like we're used to. Patients can just work on one meal at a time. So if they want to really improve their breakfast, they can just take pictures of their breakfast. So it really meets the patient where they're at. And I was surprised actually for my bedtime snack here. Again, she wrote, what beautiful berries, maybe next time have a little less cereal with some milk, and I could add some nuts or seeds to increase my protein. So again, I was impressed with the type of feedback that you receive. You can also set wellness goals, and they will note what your goals are. So for example, my colleague who was also testing the app, his goal was to decrease sugar sweetened beverages. And when he took a picture of a Slurpee, they suggested perhaps he have a smaller Slurpee next time, and reminded him that one of his goals was to decrease his sugar content in his diet. So you can also press the coach tab at the bottom, and there is a virtual coach who pushes out information in the app. So each week has a theme, and they do progress check-ins, etc. And then there's also a group chat where all the participants who start around the same time can provide peer support to each other. And this is monitored by the coaches as well as information from the virtual coach as well. So the virtual coach wrote, week 47, how's everybody doing? Let's take a moment to pause and reflect. What's your goal when you started? Where are you achieving your goal? Just some comments to help get the conversation going so the participants can support each other. And that's part of the original DPP curriculum, was to have peer support in supporting people achieving their goals. And then lastly, the last tab is the library. So again, each week has a different theme based on the diabetes prevention program curriculum. The first 16 weeks of the program are focused on education and achieving behavior change. And then the remaining 36 weeks of the 12-month program are focused on maintenance of those behavior changes. So again, I'm really impressed with the short snippets of information that is very practical, evidence-based, aligns with our Canadian guidelines, and just really interesting and easy tips to follow to help people make behavior change towards weight loss. And you can go back to previous weeks. So you can, last week was changing up your meals, and there will be, again, you can click on each of these topics and read a blog or watch a short video or a link to a recipe. And same with physical activity as well. If you have a problem with your knee, for example, you can tell the coach in the app, and they will just send you exercises to make sure it protects your knee, etc. So very user-friendly. I'm very impressed with how it works. And, it's just so easy to take a picture of your food and get that feedback. So I'll stop sharing. And Catherine, if you want to bring up the slides again. Yes, Health has been around for 15 years, and they do have an 87% completion rate of people who do the full 12 months of the program. On average, patients spend about 6 minutes a day in the app, and the average weight loss that they've recorded over the years is 6% of the starting weight. Maybe go to the next slide, Catherine. So right now, these are the PCNs in the clinics who are recruiting that we have participating so far. So as you can see, Red Deer is leading the charge, but we have good geographic spread across the province. But again, we are looking to partner with more primary care providers to increase the number of patients to participate. Next slide. So we started in February, as Peter mentioned, and recruitment's been slower than we expected. We have room for up to 500 or so patients, and we are recruiting to the end of January of 2023. So we have lots of room to add more patients. And next slide. So with that, I'm going to turn it over to Dr. Jane Ballantine to describe to you a little bit more what's involved for primary care. Oh, you're on mute, Jane.
Good evening, everyone, and thank you for joining us. Thank you, Kathy. That was very, very helpful to understand how well it works, and I appreciate your professional opinions about the validity and the rest of it. That's what we felt when we chose this, but I'm glad to have that validated, so thank you. But as Kathy mentioned, enrollment had begun in February of this year, and recruitment will close in January of next year. There's still lots of room. So which of your patients are eligible? Albertans over the age of 18, A1C between 6.0 and 6.4% within the last 12 months, BMI over 25. And that's pretty much it. Basically, they can't have a previous diagnosis of diabetes. They have no history of eating disorder and not currently enrolled in a bariatric specialty care program. So what does that mean? That means that they can't be on the road to bariatric surgery and in that highly specialized program. However, they can be still involved with you, with your team. They can be on metformin as long as no previous diagnosis of diabetes. And in addition, they can be taking weight loss medications if you've already been working with them to try and help them lose weight. So weight loss medications such as Saxenda or off-label use of Ozempic, patients can still qualify. What's interesting is because of this program, I've been looking at my patients for some time and thinking you'd be a good patient for this program. However, I already hooked them up with our chronic disease management nurse, and some of them have dropped their A1Cs under 6, so don't qualify right now. So just keep in mind that the A1C range is 6.0 to 6.4 within the last 12 months. All right, so what's involved? So based on my discussions with my primary care colleagues right now, I think the one word that describes how most of us feel at this point in time is overwhelmed. So just like patients, if it's not too much work, then I would say that if it makes more work for physicians, this probably is going to feel like it's not going to go. So what did we do in our clinic? In our clinic, we said, well, we need to sign a research agreement, but first let's all talk and say, do we want to do this? So our clinic agreed. We have one custodian. That custodian signed the research agreement on behalf of all of the physicians in the clinic. And we said, who wants to be the champion? Well, to tell you the truth, our chronic disease management nurse wanted to champion this because she loves this stuff. So if you are so lucky to have a primary care network individual in your office who is a chronic disease management nurse, doesn't have to be a CDE, but if she is, it helps, or a dietitian or someone else involved on your team, they can become the champion. And basically what happens is that by identifying a champion, then that's the person who'll do the initial contact with the patients. If it feels like it's too much for you as a physician, then look around and see which of your staff members might get excited about this sort of thing. So basically the champion or the individual who's tasked with that role contacts the patients who might meet the eligibility criteria. But what we've learned is that it's really important that the primary care doc have an initial conversation if the opportunity presents. And hand off the patient to the staff member, because we found that it's a different conversation if that happens. But the process is simple. The patient is contacted by the champion. They go through an initial appointment survey, which is literally about 5 minutes. And then patient's readiness to change may be assessed by yourself, as the physician may be assessed by one of your team members. But if they're interested, you send in the initial survey, and then the team takes it from there. Basically, at that point in time, then the then basically they go through and collect the baseline information. And of course, your patient has every right to choose to participate or not. And obviously, consent is important because they're going to collect information about patients. All right, so the registration survey gets emailed to the patient. Monthly patient stats can be reported to the clinic, usually to the champion, and it's optional to participate in the evaluation surveys and interviews. So Catherine, thank you. So what we've learned is there are a lot of patients who are eligible. Then there's probably a smaller percentage of those that you're going to contact or your champion's going to contact. But more importantly, think about who's really ready. Who's going to commit to 12 months of this? And everybody goes, oh yeah, well, what about using smartphones? I got an older practice. Well, I found that interesting, but when I told them about taking pictures of the food, they go, I take pictures of my grandkids all the time. So my older patients haven't really said that was a startler. And patients who are interested and ready, and who are willing to buy in, there's a smaller percentage of them who carry it through and who sign up. But if we could get the patients to do this, to validate it in the Alberta context, which is what it's looking like happening, then just think that if this program were available to Albertans who have pre-diabetes, we finally, as primary care docs, have something to offer our patients at this stage of the game. And as we all know, although this triangle comes down to a point in terms of a smaller number of patients that sign up, all of us know that if we don't do something about pre-diabetes, this triangle literally flips, and our patients go on to develop diabetes, the comorbidities that go with it, the chronic diseases, and the amount of let's put it this way. We have an opportunity to change the trajectory of our patients' lives at this point when we know it makes a bigger difference than at any other stage in the game. So, like I said, patient readiness is important. There are patient goals. And Catherine, if I may ask, if we go back one for just a second. On this slide, patients get a chance to goal set. Patients tell us that weight loss is really, really why they want to do this. They get great advice from the coaches. They feel a degree of accountability. And my hunch is that the more connected they are with your practice, nurse, yourself, that I think the accountability will be greater. They are motivated to exercise, and the feedback has been quite positive. Learning portion control is something that none of us have time to talk to our patients about, even if we're good at it. So I would say I think it's important that having this availability for patients is wonderful. So thank you. If we'll go to the next slide. Sorry. So patients do need to be able to commit for 12 months. So if you don't think that's possible, then maybe that wouldn't be a patient who would qualify. But for the most part, most of our patients could qualify easily. So how did we go about it? We asked our primary care network information person. Great job for them. Get them to go through Dr. Ballantine's list of patients and say, here are the patients who have an A1C between 6.0 and 6.4 over the age of 18 and a BMI of over 25. Here's your list, Dr. Ballantine. I then turned around and said to our chronic disease management nurse, knock yourself out. If I saw them, I spoke to them. I tried to speak to them, either a virtual visit or an in-person visit if they were coming in, to try to encourage patients to sign up. They would see the nurse would take it from there. One of the things some of our colleagues have done is put EMR alerts in that when patients fall within the prediabetes range, so it's a reminder to speak about it. The physician assessment of readiness. No one knows our patients better than we do. So it's not like you have to ask them a bunch of questions. You only need to have a couple of questions to know if your patient's interested. You've already had the conversation 3 or 4 times about what they're interested in. Maybe this is the opportunity, and a warm handoff from the physician is very, very helpful to motivating patients to participate. Next slide, please. So if you're interested, and I said we needed a scan, or we needed to be able to scan this because our younger colleagues are going to be way more likely to do that than myself, but it's a quick way to make contact. The virtual diabetes prevention program at ahs.ca is easy to remember. The website is www.ahs.ca/VDPP. And just to put it into perspective, in all of my years in practice, I have not seen a ground level resource that I've been able to refer my patients to that have come as validated, evidence-based, and even vetted now by our colleague Kathy, is an amazing resource to be able to offer our patients. So at least in the pilot, let's get as many patients this opportunity and let them give feedback to find out if it works in the Alberta context. In terms of an excellent resource for primary care physicians to decrease the number of our patients who progress to type 2 diabetes. Isn't it amazing that we have an opportunity that's evidence-based, that shows, that can prevent that progression? There's no question this is grounded in evidence. It's vetted on evidence. It's basically assessed against the evidence and has stayed true to fundamentals of the program. Just for the record, Yes Health is out of UC San Francisco and has a stellar group of people behind it that are making it work, and they've shown that it's worked very, very well in some of the marginalized populations in the California setting. And so I'm saying to you, think about your patients that could best benefit, who could engage, who might be interested, who are motivated at this point in time to engage, to do something to improve their own health. And think about it that you're looking at a way to help prevent your patients with prediabetes going on to develop diabetes. So please watch the video on the website, use the QR code to go to the website. And I believe the next slide is a list of references, just to show that we've done our homework. We've looked into these things in depth. We have vetted a number of these programs, and this was definitely the winner. And so I hope that you would consider enrolling patients. If you have any questions, please put them in the Q&A. And I believe I'm going to turn it back to Rose, who's going to be in charge of the panel.
Thank you so much. So that's a very exciting intervention that you've described, and I certainly am on the lookout for the pre-diabetes patients that might benefit that I'm coming across. And we've got a few questions to get us started. So the first question we have is to Kathy regarding the weight tracking feature in the app. May I ask what your opinion is on the most current trend of weight-inclusive nutrition counseling? Some dietitians suggest that weight not be set as a goal, or it should not be tracked.
Okay.
Comment on that. Yeah.
Very, very good question. So yes, yes, as we know, the trend is to, health at any weight. With the diabetes prevention program, long-term outcome study, and as we know, that weight loss is the main outcome that actually decreases the insulin resistance, which actually then is what is delaying or preventing the diabetes. So it is a key outcome. However, the coaches do, really focus on just healthy behavior change. Weighing in is something that is discussed with the patients. Some patients aren't weighing themselves because they're not comfortable, which is fine. They're just logging their food and discussing their activity with the coaches. So I think, for the purpose of diabetes prevention, weight loss, we know, is the key outcome, which leads to delaying or preventing type 2 diabetes. So it is more of a focus in this particular program. I don't know, Peter or Jane, if you want to weigh in on that.
I agree with the idea that we should be sensitive to that issue. One of the tricky parts for the provider is that when we're supporting these programs in a value-based way, what it means is we need to have some proximal outcome that proves that the intervention is going to likely create within the population served the reduction in type 2 diabetes that we saw in the studies. So if we don't have that proximal outcome, the value-based model could struggle. So for sure, for the pilot, we need people to be doing the weights, in order to demonstrate the findings from the original studies in Alberta.
If I may, I'd agree with the two previous speakers, but I'd also add that patients sometimes don't choose to weigh. However, I would say to them, if we're working on improving their health and helping them prevent diabetes, it's our responsibility as their healthcare providers to have the conversation about what that means. So it's a bigger picture than just the discussion about numbers on the scale, but numbers on the scale give us something to measure, as Peter said. In this pilot, it's important, but I also find that sometimes patients don't realize they've lost weight. And sometimes putting a patient on a scale 6 weeks after you've started working with them and they've dropped a pound, to say, look, you're going the right direction. And I go, I'd had no clue. And so I would say it's not the primary focus according to some philosophical perspectives, but it's something that the patients can do at home. And most patients, if they come in and ask about it, they don't ask about preventing diabetes, they ask about weight loss.
Thank you. So the next question I'm going to ask you to answer are, most people doing this out of the physician office, would we be able to do this from our centralized office? We receive referrals from physicians. Could we assign a champion in our own clinic and connect folks to the study? That way we would still communicate with the family physician regularly.
If I may, I'm guessing it's a primary care network centralized office. So that's the part I can't answer without knowing, but I would say the piece about sharing of information and the rest of it, you might need to write 2 agreements in terms of sharing of information. Right now, if a patient's referred to a primary care network allied health professional, I believe the care of that patient remains under the family physician.
Yes. Yeah, that's right, Shane. I can just add. So we do require that research agreement to be signed by the physician, as they're the custodian of the data. So once they have that signature, though, definitely the allied health team can take over and be the champion and communicate and do all the recruitment. And then the physician can receive copies of the reports after that. But otherwise, the physician doesn't need to be involved if they want to delegate that the recruitment function. Just the signing of the research agreement is the only piece that we need from the doctor.
Thank you. So another question is, a family member is very obese and has a family history of diabetes. How can that person access the DPP?
So we've had quite a few patients email us directly. So just email us at our email that we had there, bdpp@ahs.ca, and tell us your name, tell us who your family doctor is, what city, what clinic you're in, and then we will reach out to your PCN, and hopefully we're already connected with them, and try to get a hold of your doctor and explain the program so that we can get that research agreement signed and get you signed up. So very recently this has happened, and the family physicians are thrilled to have learned about it through their patients, and have contacted us as well to get involved. So just send us an email.
We also have a poster that if physicians are interested, they could put up in their office that allows the patients to take the first step or allows them to have the conversation with the doctor.
Yes.
And we will be happy to attach the poster to materials that will follow this presentation to all registered participants.
I just want to make sure that we answer what might have been an implicit question buried there, was could somebody qualify on the basis of a family history and their weight without having the A1C target? And the answer in the pilot is no. Was that's important?
Yeah.
So because in the question, it wasn't specified that they had an A1C that was in that range of 6.0 to 6.4, that would be required during the pilot.
So thank you. The next question is, what nutritional guidelines are being used in counseling, i.e. Mediterranean, Canada Food Guide, glycemic index, other?
I would have to say all of the above. It is, again, based on the diabetes prevention program curriculum. All the coaches have gone through the specific training for this program. And again, I think it's really about meeting the patient where they're at and working with the foods they like, the type of eating patterns that they want to follow, and just improving behaviors and habits with where they're at. So it's quite flexible, I would say, and all, Mediterranean, adding nuts, seeds, they really promote that, following, more whole grains, high fiber foods to lower the glycemic index, etc., adding protein to your meal. So all those are part of the suggestions from the dietitians.
Thank you. Is the program available to patients in Ontario or out of Alberta?
No.
So my understanding is that their physician who's signing the research agreement must be in Alberta, because that's where we're doing the pilot. I apologize, Kathy, if you.
No worries, Jane. Yes, yeah. For now, for the purpose of this pilot, it is only open to Alberta providers and residents.
Thank you. So a question from Ontario is, how do you go about promoting the program and gaining participants? We struggle with promotion and recruitment of participants in our area.
So I would say right now, if we just stop and think about the demographic of the patients we're speaking about, the majority of them are in a primary care physician's office, or they might be seeing an internal medicine physician. Don't think they should be seeing an endocrinologist or other subspecialists, but I believe that those are the best places to look for recruitment, to give patients the opportunity to sign up themselves. And in addition, I think by letting the primary care networks involved, engaging the primary care networks, these are people who are talking to our patients all the time. And we learn about what's available. We as primary care physicians learn about what's available in Alberta as resources for our patients from our PCN staff on a regular basis.
So just to follow up on some of the recruitment questions, there's some follow-up questions about patients who do not have family physicians or who have not had A1Cs but are interested. Kathy, what's your response to those people who may not have a connection to primary care right now?
Kathy, I might be able to handle that one.
Okay, go ahead, Jane.
So the primary care networks have stepped in during the pandemic to fill in the gap, and even more so now as we have lost a number of primary care physicians. So if a patient is seen in a primary care network setting, they can get the blood work done, and that physician could be asked to sign on. Primary care networks would probably be willing to do that. It might be that it's the physician who's responsible for the after hours clinic or otherwise. Those nuances can be worked out with the project team. I don't think they need to be worked out on a one-on-one basis, but definitely I believe that most primary care networks are in the business of attaching patients to primary care physicians. And if they know there's a physician who's interested, this might be the place they send a patient. So it might be a win-win-win all the way around.
Yeah, yeah, I agree, Jane.
Thank you. So the next question is about Alberta having the largest increase in diabetes over the last 10 years and projected to have the largest increase over the next 10 years. To clarify, was the highest increase across the provinces? And what are your thoughts as to why Alberta has the largest increase?
I
I
think
might have to get you to help me with this one,
Yeah.
Rose.
Yeah, yeah. This data is from the Diabetes Canada Backgrounder 2022. But yeah, Rose, if you want to weigh in.
Yeah, so sure. Alberta has one of the youngest populations, and one of the things I think about Alberta is it's also a more affluent place, actually compared to the other provinces. So that may mean more access to energy and maybe doing less physical activity. It's really hard to know. We don't actually have a clear understanding of it. It's also one of the provinces with a lot more growing ethnic diversity, which might also be a factor in why the rates are increasing. I don't know if anyone has anything else to ask or to answer on that.
The other piece is that we're constantly working to improve the quality of our data, related to our populations with diabetes and prediabetes. And so hopefully we'll be in a position as we go forward to be more precise about kind of the associated features that go with diabetes, prediabetes, and their complications. And Rose and I have worked with a group of other researchers to try to develop a bit of an improved data infrastructure related to diabetes in the province to be able to more easily answer these kinds of questions.
So kind of on that point around ethnicity, can you comment on how the food app identifies or supports people with diets from other parts of the world?
So I can make a comment on that. I did throw some different foods into my photos just to see how they responded. They handled it very well. Jay and I talked about pierogies and, all brand buds, etc. So that was one of the reasons, though, we decided to suggest CS Health to hire an Alberta dietitian coach, so that we did have that lens of the different types of food that Albertans eat with our newcomers and our immigrants, etc. So after the pilot, we will have to discuss what that looks like going forward if this is successful to move to a permanent program. But yes, that's that she's been handling most of the nutrition questions from the Alberta pilot group.
And just if I could add to that, Kathy, part of the training that the coaches receive is the ability to be familiar with a variety of cultural contexts. So that is part of their training as well, to be able to adapt to different participants' lifestyles and diets.
Very good. So partially related to what you were just mentioning, Kathy, what happens when the VDPP pilot is over? How will the program be sustained for the patients in the program?
Yeah. So Jane and I have had some conversations, so I'll let her weigh in too. But just to start it off, yes, we have put together a resource list that we will distribute to the participants once the program's over. But generally the PCNs have CDM programs or have referral to a dietitian or some referral pathway for patients with prediabetes. And then of course there's the Alberta Healthy Living Program, which any patient in the province can access no matter what zone they live in. And now there's a lot of virtual delivery from the other zones. So there's a much bigger menu of offerings from the Alberta Healthy Living Program. So I think it's just, working with their primary care providers for sustaining their behavior change. And I'm not sure, we don't know yet, again, on the long-term results, but there could potentially be an opportunity for them to continue with the program. We just don't know yet. Jane?
So I was going to say, Peter helped me, but a patient who develops diabetes costs on average what per year? Do you remember?
Oh, it's in the thousands of extra.
Yes.
Yeah.
So I think that being able to show that a significant percentage of patients with prediabetes who are on the road to diabetes have the trajectory of their lives changed, but governments look at the trajectory of the dollars. And if there's a lot less dollars spent on it, it's an argument that we take and say, look, this worked well enough that this should be available to all of the patients in Alberta. Don't know, can't speak to it at this point, but we're enthusiastic that with what DPP has done in the US, the uptake, the availability, and many insurers have taken it on. That hasn't been the way things work in Canada or Alberta in particular, but we see interest from other provinces already. So I think it will be important to show we are kind of leading, because 2 years ago, I don't think most primary care physicians talked about prediabetes. So I think we're probably early on still in trying to curb the wave before it starts to crest, if I may use that analogy.
So to follow that with the question of where do we find the consent and this survey?
So the QR code that's still up on my screen, send an email to the VDPP program, or look at the website, all of which will give you an opportunity to sign up. I believe, Rose, if I may, I saw another question about PCN versus doctors versus whatever. If the doctors are in an association and they can agree that there's a single custodian who's responsible for that custodian for any clinic can sign on. If they are individual practitioners under an umbrella where the bricks and mortar are provided by the PCN, then likely it'll be the individual physician who signs on. I hope that's helpful for that
Thank
question.
you for clarifying. Yes,
And we'll also send that out, Rose. We'll send the research agreements out to all the participants.
Thank you. So how many PCNs are currently enrolled in the program?
We have 9, and then 1 physician who's not affiliated with the PCN. And we have a total of 33 clinics and 139 family physicians participating.
Great. And there are a couple questions about prediabetes. Many people living with prediabetes might not be aware of the fact that they have prediabetes. Have you taken any actions to address this?
So I appreciate the question. I would say it sits firmly within the primary care realm. And I did mention just a minute ago that 2 years ago, no one was having the conversation. In the last 2 years, I've had a lot of conversations, and thankfully, many of my patients have gotten on a road to improve it. But to be honest, some of them don't qualify this year for the program. But I would have to say they're connected with resources and making lifestyle changes that hopefully will be both long-term and benefit them. But we're having the conversation and we're paying attention.
And we have one more question about prediabetes and the number of Albertans with prediabetes who do not have a physician. Is there any data on this? Have you looked at that within the?
So the last data I saw, but I can't tell you that it's current, was that there are about 20-something% of Albertans without a family physician. I can't tell you that that's updated. That was the last time I saw it done, and I've forgotten. I'm sure it's probably not as good, both with respect to COVID. We've lost physicians, and patients aren't as connected. And many of us are finding we're trying to reconnect with some of our patients. And I would say I get asked once a day by someone, can I take on another patient? So the majority of my colleagues are in a state of overwhelm. It's not that they're not trying. So I would say there are probably a number of Albertans without family physicians. I can't tell you the demographic of those patients, so I can't tell you if they're more likely or less likely to be pre-diabetic. But I would tell you the number of patients coming out of the woodwork after 2 years of COVID and no blood pressures done is scary. So
I should say that there are point of care testers now that can be deployed in the community, and we are doing some studies on with hard to reach populations about doing screening fairs where we do that point of care testing, and so it might be something that we have more options to do in the future, as public awareness campaigns where people can attend one of these events and be tested, but right now we don't have that kind of formalized, but we are thinking about it.
Okay, I think that segues into the last question we'll answer tonight, which is, given the number of people who would need this program that probably don't see a physician regularly, is there any way to reach the general public to encourage them to get checked by their doctor or engage them to follow up with a VDPP?
So personally, I'd start with family members with diabetes are probably your strongest indicator that you're at risk of diabetes. The fact that most individuals know that carrying around extra weight and sedentary lifestyle, that's not because we've taught them well, that's because that's general knowledge. But having said that, there are guidelines about testing, and as patients reconnect with physicians or get a chance to connect with physicians, I think primary care is doing its darndest to get some of that, those screening tests done, and then have the follow-up conversations that fall out of it. As everyone in Alberta knows, our patients were told not to do hemoglobin A1Cs because there were no purple top tubes. So we've had some mixed messages and we do have some work to do. So I would say, in the best interest of one, knowing that there's something that we can make a difference in, I think primary care gets excited. I know I do as a primary care physician, when there's a place to make a difference that can dramatically change the trajectory of a patient's health if we just look for it. So, and this feeds into that. So I think that's what we need to get back to in primary care.
Prevention is the key. Underline, highlight, exclamation mark, and is supported by this intervention. So at this time, I'd like to thank all our speakers and thank you for attending tonight. Please do fill out the evaluation and let us know what you're looking for from the Office of Lifelong Learning, and what kind of materials and talks you'd like to see in the future as well. To remind everyone, we will be offering 2 more parts to this diabetes and endocrinology theme, or is it 3 more parts? I'm losing track. 2 more parts.
3 more parts.
3 more parts.
Yeah.
3 more parts. That's right. So we have got an excellent talk on diabetic foot with Dr. Yan coming up, as well as a talk from Dr. Kate Potter, a pediatric endocrinologist, on the top 10 endocrine peds endo tests you need to know about, as well as a very interesting talk about another very useful intervention offered to patients with type 2 diabetes and food insecurity that is recruiting. So that will be happening in a few weeks' time, and the notices are on the Office of Lifelong Learning website. So thanks once again for this illuminating talk, and I hope you all try and find those people who can benefit and can help to evaluate this pilot and hopefully change their lives as a result of being part of such an exciting intervention. So take care, stay safe out there, and good night. Bye-bye.